Welcome to the 21st Century Man podcast. We're back with another deep dive, this time into a really critical chapter from the 21st Century Man.
That's right. Today we're looking at Chapter 10, Managing Persistent Pain, a hugely important topic.
Absolutely. If you've ever struggled with chronic pain, or you just want to understand it better, well, this chapter, and hopefully our chat, will offer some really solid insights and, practical steps.
It really does. Dr. Launton lays out the key concepts clearly, highlights actionable advice, and helps demystify some of the more complex medical terms.
Yeah, our goal here is to give you a clear understanding of how to navigate and manage persistent pain, pulling directly from what's shared in this excellent book.
And we should say, well, we'll cover the highlights. Reading the full chapter and really the whole book, The 21st Century Man, gives you that complete picture. It's highly recommended.
Definitely. So let's jump in. The chapter starts by just, wow, hitting you with the sheer scope of chronic pain. The statistics are kind of mind-blowing.
They really are. Get this. The book states more people live with chronic pain than have cancer, heart disease, and diabetes combined.
That's incredible. So over 116 million Americans dealing with chronic or severe pain, compared to what, like 15 million for cancer, 25 million heart disease, 30 million diabetes?
Exactly. It just dwarfs those other major conditions in terms of numbers affected. And specifically for men, the estimate is over 40 million dealing with chronic pain.
40 million. So yeah, this isn't some niche issue. It's incredibly widespread.
Which is why understanding it is so crucial. The chapter then does something interesting. It kind of reframes pain itself.
Right. It talks about the life-saving value of pain, which sounds counterintuitive, maybe.
Well, yeah, we think of pain as bad, but it's our body's alarm system,
Yeah.
It detects injury, tells us something's wrong, and kickstarts the whole response.
Like touching something hot, that immediate pain saves you from a serious burn. It's a survival mechanism.
Precisely. And then the healing process kicks in, repairing tissue, calming inflammation. But the book points out that our ability to heal efficiently tends to decrease as we age.
Ah, okay. And that connects to chronic pain, how?
Well, if that healing process gets disrupted or slows down too much, it can lead to ongoing tissue damage, sort of chronic degeneration, and that, in turn, fuels persistent pain.
Makes sense. So the body isn't fixing things as well, leading to ongoing problems. This brings us to a really key distinction the chapter makes: acute versus chronic pain.
Yeah, understanding the difference is fundamental. Acute pain is that sudden, sharp response to immediate tissue damage, like a cut, a sprain, something specific.
It's triggered by those things called nociceptors, right? The body's injury detectors for heat, pressure, that sort of thing.
Exactly. They send a signal up the nerves to the spinal column, then bang up to the brain, resulting in that quick action, like pulling your hand away.
But chronic pain, that's different. The chapter mentions this idea of the pain brain. What's that about?
Right. So imagine repeated trauma or nerve damage or just constant inflammation. Over time, the actual pain pathways in the nervous system can change. They can become hypersensitive.
So more sensitive to pain signals.
Yes. And you can get nerve inflammation itself, leading to what's called chronic neuropathic pain. It's like the volume knob for pain gets stuck on high, even if the original injury is healed.
Like the alarm system is malfunctioning. That sounds rough.
It is. And that's why Dr. Longton really emphasizes getting an accurate diagnosis early on, especially for that nociceptive pain, the kind caused by actual physical damage like an injury or arthritis.
Because catching it early might stop it turning into that chronic neuropathic kind.
Potentially, yes. Early intervention is really key to preventing that transition.
Okay. So what about treating that initial acute pain? What does the chapter suggest?
Well, the standard approaches usually involve reducing inflammation first. So think ice, anti-inflammatory medications, that sort of thing.
And sometimes they try to block the pain signals directly.
Right, using things like anesthetic nerve blocks or maybe cortisone injections to calm things down locally.
And what about stronger pain meds, like opioids?
The book mentions they might be used short-term for severe acute pain, mainly to sort of mask the pain enough to allow for some mobility and function while the initial healing happens, but strictly short-term for acute situations.
Gotcha. Because if pain does become chronic and goes unchecked, the consequences can be pretty severe, right?
Absolutely. Those dysfunctional or neuropathic pain pathways can lead to all sorts of problems. Chronically swollen tissues, those hypersensitive pain receptors we talked about.
Nerve endings that just seem to prioritize pain signals.
Exactly. And importantly, the chapter notes that these ongoing pain signals can even affect brain processes in a way that contributes to depression. It's a complex cycle.
It really sounds like it affects everything. And the book points out this becomes much more common as we get older.
Definitely. The stats show a clear trend. About 7% prevalence in young adults, 18-24, jumps to 22% for the 45-64 age group.
And even higher after that.
Yet 27% for those 65 and older. It clearly increases with age.
And the economic cost is massive too, isn't it?
Huge. The chapter cites over $500 billion back in 2010 in the U.S. alone. That includes healthcare costs, lost workdays, disability. It's an enormous burden.
Okay, so to make this more concrete, the 21st century man uses a couple of common examples, like lumbar disc degeneration and osteoarthritis. Let's talk about disc pain first.
Right, lower back pain from discs. The book says it's almost universal. Pretty much everyone gets some level of it by age 40.
Wow. And what causes it typically? Just wear and tear?
Mostly, yeah. Repeated strains, overuse. But the chapter also mentions emerging evidence about potential infection playing a role sometimes, plus, of course, just the aging process itself.
And walk us through what happens to the disc as it degenerates.
Okay, so you get little tears in the outer layer, the annulus. Then the inside bit, the nucleus, gets damaged, loses water content. So the disc gets less cushiony, loses height.
And that affects the bones around it.
Yeah, the vertebrae can shift slightly. This causes inflammation around the disc in the little facet joints nearby, irritates the nerves, causes muscle spasms.
Sounds like a cascade of problems.
It can be. Then you might get nerve compression, think sciatica, that pain down the leg. Over time, degenerative arthritis can set in, bone spurs might form.
And that can lead to spinal stenosis.
Right, the narrowing of the spinal canal, which puts even more pressure on the nerves. It's a progressive thing.
And the book mentions younger men might experience more inflammation, while older men get more stenosis.
That seems to be a general trend, yes. Different manifestations depending on age.
And I love that little fact about astronauts getting back pain because their discs expand in space.
Yeah, fascinating. Shows how much gravity affects our spines day to day.
Okay, let's switch gears to the other big example, osteoarthritis, the wear and tear kind.
Exactly. Classic age-related joint issue. It's the breakdown and loss of that smooth cartilage covering the ends of bones in our joints.
And like disc pain, it gets way more common with age.
Significantly. Around 10% at age 45, up to 30% by 60, and potentially 50% by age 80.
And the underlying reason is again related to aging cells.
Yes, our tissues just don't repair themselves as well as we get older. And while some people are naturally more resilient, factors like biomechanical stress, carrying extra weight, poor joint alignment, they can all overload the joints.
And the book flags certain lifestyle factors that can actually speed up this joint degeneration.
Right, things like smoking, obesity, diabetes. And interestingly, it also mentions stress and depression as potentially accelerating factors.
Which leads nicely into the next section in the chapter, focusing on lifestyle factors and chronic inflammation, starting with smoking.
Yeah, the link between smoking and increased chronic pain, especially low back pain, is pretty strong according to the chapter.
And it's not just one thing, is it? The toxins seem to affect tissues in multiple bad ways.
Absolutely. The book details how nicotine and other nasties in smoke can negatively impact the immune response, tissue regeneration. They weaken discs and joints, inhibit cell growth in the discs, constrict blood vessels.
Damage collagen, affect the skin.
Yes, all of that. Plus, weakening the outer lining of the disc. There are even MRI studies mentioned showing smokers lose knee cartilage faster.
And that hypoxia thing reduced oxygen from carbon monoxide that puts extra stress on joints with already poor blood supply.
Exactly, like the lower back and knees. Smoking really does a number on connective tissues.
Okay, what about obesity? How does that tie into chronic inflammation?
It's a key factor. Excess body fat actively produces more pro-inflammatory chemicals, like TNF-alpha.
And there's evidence for this.
Yeah, the chapter mentions that patients who have weight loss surgery, like gastric bypass, often show a significant drop in these inflammatory markers afterwards. It clearly shows the link between excess weight and systemic inflammation.
And then there's the connection between stress, depression, and inflammation. They often seem to go together with chronic pain.
They do. And the book points to research showing that people with depression often have higher levels of those pro-inflammatory markers.
What's the mechanism there? How does being stressed or depressed increase inflammation?
Well, a few things might be going on. Reduced vagal nerve tone. That nerve helps calm inflammation, so if it's not working well. Also, an increased stress response generally, and potentially slower cell healing. It's complex interplay.
Okay, so after outlining these problems, the chapter thankfully shifts to lifestyle strategies to actually combat chronic pain. Exercise comes up first.
Yeah, beyond the well-known benefits for heart health and weight, the chapter highlights something specific. Even just 20 minutes of exercise can lower those pro-inflammatory chemicals like TNF-alpha.
So exercise directly helps calm inflammation and improve healing.
That's the takeaway, yes.
Yeah.
Even moderate activity makes a difference at a cellular level.
Then breathing techniques. We breathe all the time anyway.
Right, like 20,000 times a day, the chapter says. So plenty of opportunity to practice techniques that improve the control and tone of that vagus nerve, which, as we said, helps regulate inflammation.
Simple but potentially powerful. What about mindfulness meditation?
This is really interesting. The book cites brain scan studies, fMRI studies, showing that meditation can rapidly increase pain tolerance, even in beginners.
How does it do that?
It seems to improve blood flow to the parts of the brain involved in processing pain signals, basically changing how the brain responds to the pain.
And there are resources to help people try this.
Yeah, the chapter lists apps like Headspace, books, podcasts, even devices like HeartMath. Lots of ways to get started.
Okay, now on to nutrition. This gut inflammation connection seems really important.
It's a rapidly emerging field. The chapter talks about the gut microbiome, all those bacteria in our digestive system, and its potential role in osteoarthritis.
So the bugs in our gut might affect our knee joints.
It seems so. Studies are finding links between specific types of gut bacteria and low-grade knee inflammation, even arthritic pain, and interestingly, it seems separate from just being overweight.
And this might apply to the spine too.
Possibly. The chapter mentions differences in bacteria found near healthy versus degenerated discs, suggesting our gut flora might influence disc inflammation, maybe even susceptibility to infection.
Fascinating. So diet becomes really important for managing this, an anti-inflammatory diet.
Exactly. The goal is to optimize that gut flora. The chapter recommends an overall healthy pattern, specifically mentioning the Mediterranean diet.
Lots of fruits, vegetables, nuts, whole grains, fish, healthy oils.
Right. Olive oil, leafy greens, fatty fish, berries, cherries, things rich in antioxidants, and these compounds called polyphenols.
Even coffee gets a nod.
Yep, contains polyphenols and anti-inflammatory compounds too.
And on the flip side, things to avoid.
The usual suspects. Refined carbs like white bread and pastries, fried foods, sugary drinks, red and processed meats, margarine, lard, things known to promote inflammation.
And beyond specific foods, the chapter gives tips for optimizing gut flora generally.
Yeah, things like cutting unhealthy fats, eating way more fiber, adding fermented foods like sauerkraut or miso, maybe probiotics, avoiding unnecessary antibiotics, reducing stress, not smoking, getting enough sleep, and exercising. It's really a whole lifestyle approach.
It all connects. Okay, let's move into the clinical strategies for pain management that the book covers. What are the common medical treatments?
The chapter outlines the main categories: medications, exercise programs, non-medication therapies like massage or acupuncture, interventional treatments like injections, and sometimes minimally invasive surgery.
Let's break down the medications. NSAIDs first, the anti-inflammatories.
Right, common for both acute and chronic inflammation. The book mentions diclofenac might be particularly effective in some studies for arthritis pain, but it needs a prescription and careful monitoring due to potential side effects on kidneys, liver, or causing stomach bleeding.
What about over-the-counter options?
Naproxen is mentioned, maybe preferable for some because it lasts longer. And for localized pain, topical creams or gels like Voltaren gel, lidocaine patches, capsaicin can be helpful, especially for smaller areas.
What about medications for nerve pain, that neuropathic burning sensation?
That's where certain antidepressants or anti-seizure medications often come in. Gabapentin, Lyrica, Cymbalta are examples mentioned. They work by dampening nerve transmission, but a common side effect can be drowsiness.
And again, topical options exist here too.
Yes, things like lidocaine patches, topical NSAIDs or capsaicin applied directly to the painful joint or area. Diclofenac gel, for instance, is noted as effective for joints close to the surface, like hands or knees, with less getting into the whole system.
Okay, moving on to supplements and botanicals. Does the chapter find strong evidence for them?
Well, it mentions a big review, a meta-analysis, that found some supplements might offer short-term pain reduction in osteoarthritis, things like L-carnitine, curcumin, frankincense. But crucially, it found no long-term clinically significant effects.
So maybe some temporary relief, but not a long-term solution based on that review.
That seems to be the conclusion cited. The chapter does mention magnesium deficiency being linked to inflammation, and zinc supporting the immune system.
And curcumin and frankincense come up again?
Yes, curcumin from turmeric is noted for its anti-inflammatory properties. Frankincense, or boswellia, is also mentioned for reducing inflammation and pain, potentially quite quickly.
And using them together might be better?
Some studies suggest combining them increases potency, especially for knee osteoarthritis, and they might be easier on the stomach than NSAIDs for some people.
Now, the really tricky topic, prescription opioids. What's the book's stance?
Very cautious. It states their use for chronic non-cancer pain is controversial because the evidence for long-term benefit is limited, while the risks of harm, including addiction, are significant.
So they should only be a last resort.
Essentially, yes. Only if other non-opioid therapies haven't worked well enough and the pain is severely impacting function and quality of life. And even then, the benefits have to clearly outweigh the risks.
And they should be part of a broader plan.
Absolutely. Combined with non-opioid meds, physical treatments, and requires really careful monitoring for misuse, especially in people with risk factors like a history of substance use or mental health issues. Other options like NSAIDs, certain antidepressants, anti-seizure meds should always be tried first.
Are there other ways opioids are used?
For very severe intractable pain, the chapter mentions implantable pumps delivering opioids directly to the spinal fluid. And it notes research into newer opioids that might target pain receptors outside the brain, potentially offering better safety.
Okay. This all sounds complex to navigate. Finding the right doctor seems critical.
Totally. The chapter advises looking for physicians who are fellowship trained and board certified specifically in pain medicine. Their background might be in anesthesiology, neurology, physical medicine, psychiatry.
And what do these specialists do?
They can manage medications, refer for therapies, and importantly, they often perform those interventional procedures like nerve blocks or spinal injections. They know the whole spectrum of treatments and when to use what or when to refer on.
How should someone prepare for a visit with a pain specialist?
Be ready to give a detailed history, not just medical history, but specifically about the pain. When it started, location, quality, intensity, timing, what makes it better or worse.
Bring records.
Yes, gather any imaging reports, lists of treatments or meds you've already tried. It helps the doctor enormously.
And have questions ready.
Definitely. Ask about the diagnosis, the prognosis, the treatment options, starting with conservative ones. And if they suggest interventions, ask about their experience with those specific procedures. Also, ask how you can optimize your own health to help manage the pain.
Let's touch on some of those specific interventions mentioned. Injections.
Yeah, injecting local anesthetics and cortisone near nerves or into joints is common. It aims to interrupt pain signals, reduce inflammation, restore mobility, maybe even reset those dysfunctional pathways. Epidural or facet joint injections in the spine are examples for back pain or sciatica.
Nerve blocks, too.
Right. Usually quick procedures, often using X-ray guidance, fluoroscopy for safety and accuracy. The anesthetic gives rapid relief. The steroid gives longer anti-inflammatory action.
What about shockwave therapy?
The chapter mentions it for certain conditions like pain around the hip, trochanteric pain, tendon issues in the knee or Achilles, plantar fasciitis, often done by sports medicine docs.
And then more advanced things like minimally invasive surgery.
Yes, options like nerve ablation, using radiofrequency energy to essentially deactivate specific pain-sensing nerves, or neurostimulation, implanting electrodes to modulate nerve signals.
What conditions is neurostimulation used for?
Things like persistent pain after back surgery, complex regional pain syndrome, CRPS, certain types of limb pain, phantom limb pain, other nerve pain issues.
Are there advancements happening there?
Yeah, the book mentions newer high-frequency stimulation that patients might not even feel, offering good relief for chronic nerve pain. Also, things like PRP injections to promote healing, and even implanted vagal nerve stimulators being explored for pain, possibly via anti-inflammatory effects.
Vagal nerve stimulators, like the ones used for epilepsy.
Similar idea, yes. The vagus nerve is involved in so many bodily functions, including inflammation. There are even external non-invasive devices now.
And radiofrequency energy can be used in other ways, too.
Right, to target sensory nerves around joints like the knee, or even specific nerves within the spinal discs or vertebrae for certain types of back pain. And minimally invasive spinal surgery itself offers smaller incisions, maybe faster recovery.
Okay, lots of clinical options, but what about self-management? The chapter uses low back pain as an example again.
Makes sense. It's so common. Up to nearly half the population experiences it at some point. Risk factors include smoking, obesity, age, certain types of work, job dissatisfaction, psychological factors like anxiety and depression.
But most cases are nonspecific, right? Like muscle or ligament strain.
That's the most common diagnosis, yes. And the good news, the chapter says, is the vast majority get better within a couple of weeks with just brief rest. Though avoiding prolonged bed rest is key. Maybe some NSAIDs or muscle relaxants.
What if it doesn't get better?
If pain persists beyond 2 to 4 weeks without improving, that's when the chapter advises seeking medical evaluation for potential physical therapy, massage, chiropractic care, maybe imaging, or a referral to pain management.
One last interesting area the chapter touches on, potential differences between men's and women's pain.
Yeah, it's quite intriguing. Some research suggests women might have slightly lower pain tolerance in experimental settings and may need higher doses of some pain meds.
And women report chronic pain more often.
Yes, a higher percentage of women report chronic pain. And certain conditions like fibromyalgia, migraines, IBS, TMJ pain are significantly more common in women.
Any theories why? Genetics?
Hormones? Both are mentioned as possibilities. Some pain-related genes are on the X chromosome, which women have 2 copies of. Hormonally, testosterone might offer some protective effect against pain for men.
So there might be biological reasons for different pain experiences.
It seems likely. There are natural variations in how readily individuals transmit pain signals anyway, and in rare cases, genetic mutations can even cause a complete inability to feel pain.
Wow. Okay, so wrapping up the key takeaways from this chapter.
Chronic pain is incredibly common in men, particularly midlife. Minimizing chronic inflammation and promoting tissue healing are absolutely crucial. There's growing understanding and new interventions offering hope.
And the focus should be on reducing that chronic cellular inflammation through all avenues, devices, medications, and especially lifestyle changes.
Exactly, and the chapter even hints that future developments in longevity science might one day help prevent chronic pain altogether.
And that final thought from the chapter really hits home, doesn't it? The most common question men ask is, when can I play golf again?
It perfectly illustrates how much pain impacts quality of life and the things we value. It shows why managing it effectively is so important and why this chapter of the 21st Century Man is so valuable.
Couldn't agree more. We've just covered a lot from Chapter 10, Managing Persistent Pain in the 21st Century Man. We really hope this deep dive gave you some valuable insights into just how complex chronic pain is, but also, importantly, the range of strategies available to manage it.
The chapter really drives home the power of lifestyle, the potential of different therapies, and the absolute importance of working with knowledgeable healthcare providers.
It really does. We absolutely encourage you to grab a copy of The 21st Century Man, explore this chapter fully, and honestly, the whole book is packed with essential information for navigating health today.
A truly fantastic resource.
Please join us next time on the 21st Century Man podcast. We'll be diving into another vital topic with Chapter 11, Coping with a Chronic Lung Condition. We look forward to continuing this journey with you then.